camera if you good. But good morning, everyone. Welcome to our third launching inclusive cancer care LBTQ SOGI data initiative. This is number 3 of our webinar series. We are here today with some wonderful guests, Dr. Hayden Shafer, Midori Kondo, and Mary Beth. They are all here to share their knowledge with us today. So we're so excited to have them with us for this webinar. Today, we will be focusing on inclusive practices within electronic health records. So we'll go on ahead and jump in. This will be a really exciting workshop, so we'll share a little bit of the features that we'll be utilizing today. We'll be having a Q&A session at the end for about 30 minutes or so. This will be a dynamic Q&A hosted by HIMSS, by Mary Beth and Midori. So we're very excited to have that. So please save your questions to then. Feel free to interact with us. This will be an interactive presentation. We'll have polls, we'll have questions throughout the presentation that we'll ask you all to answer. Any unanswered questions that you may not get to answer today, we will be following up after the webinar. So feel free to still throw them in the chat and we'll make sure that they get answered with a follow-up email. We will be recording this webinar as it's being recorded right now. And please ensure that you are muted if you are not talking, just for the respect of our speakers today and for everyone else who is interested in listening. Here's a little bit of our agenda. We'll start off with a few acknowledgements. We'll talk a little bit about the California LGBTQ Health and Human Services Network, a little bit about HIMSS as well, our Southern California chapter. We'll pass it on to Dr. Hayden Shafer to talk about all the interesting information today, and then we'll close with our Q&A. So I'd like to start by doing a quick land acknowledgement. I want to acknowledge the land that we currently are on. I know we are virtual today, so folks are in different places all over. Today, I am joining you from the occupied territory of the Nisenan, Miwok, and Padawin people in the Sacramento area. I also want to acknowledge the Tamba and Chumash people whose lands make up the LA area, where a lot of our attendees are joining from. And I also want to honor the lands of all the people that are here today. There's a lot going on in our world currently. I'm sure we're all aware. It weighs on all of us heavily. And so I want to acknowledge that as well. And thank you all for deciding to show up today and make a difference in your community, especially with what's going on today. So truly appreciate you all taking the time to have some knowledge. A little bit about the California LGBTQ Health and Human Services Network, if you haven't heard of us. We are an LGBTQ specific program of Health Access California. We bring together more than 60 nonprofit providers, community centers, and researchers and advocate for state-level policies. Lots of things that advance LGBTQ health. We have some really amazing programs. We have We Breathe, which supports eliminating tobacco use by 2035. And we provide expertise on LGBTQ communities in reducing tobacco use. We also have Out Against Big Tobacco, which is our LA coalition. And we have a lot of LGBTQ individuals and organizations addressing tobacco control. And we also have the LBTQ Health Equity Initiative, which is actually this initiative that this webinar is covered under. And I'll talk about what we do in just a few. But the network truly seeks to, to expand coverage and improve access to quality healthcare, to strengthen programs and build capacity. We try to increase funding to LGBTQ health and human services organizations. So we've been doing a lot this year. And I do want to acknowledge the folks that are in the room that are also helping out with this work. Ariella, Lou, Isaias, we have quite a lot of folks that are doing this work. And so happy to uplift them and also appreciate them for doing this work as well. So a little bit about the LBTQ initiative. This was an initiative that was launched in assistance by the California Department of Public Health, CDPH, to address significant health disparities affecting 2.5 million Californians who identify as LBTQ. This program specifically hopes to tackle systemic anti-LBTQ bias and lack of culturally responsive care, build capacity of service providers, and deliver culturally, linguistically, responsive care, and strengthen the continuum of care for LBTQ Californians. And so that is why we're doing these webinars, to make sure our community knows that we are looking out for them and that we want them to be educated. And so we're happy to be able to do this. This initiative actually concludes next year in March. And so this is one of our final webinars that we will be sharing with everyone. So we're happy that you all are here. And these are the folks, the wonderful folks, a few of them I named. Danny is also our network director. Shannon, unfortunately, cannot be here today, but that is our evaluator. And so these are the beautiful faces behind the folks that are doing this work. So just wanted you to be able to see some of them today. Without further ado, Mary Beth, I will pass it over to you to talk a little bit about HIMSS Southern California chapter.
Awesome. Very good. Thank you so much. We can go to the next slide. So HIMSS Southern California is proud to be a part of this initiative. When Midori Kondo was our chapter president, she was part of writing the grant to get this initiative covered and get education out to everybody. So HIMSS as an organization stands for the Health Information Management System Society, and the vision of the organization as a whole is to realize the full health potential of every human everywhere. I won't read the whole slide of the mission to you, but it really is the why and the how we do this and we come together. And we'll share this more afterwards. Next slide, please. Currently, it takes a lot of volunteer effort. Our chapter is run solely by volunteers, and this is our executive board, as well as all of the folks that are coordinating our various events. Our Southern California chapter is one of the most active chapters in the nation, bringing together healthcare and technology leaders to collaborate, learn, and innovate. Our membership typically spans not only providers, but payers, consultants, and industry partners, all who are committed to advancing healthcare through technology. We host flagship programs like our Winter Healthcare IT Collaborative in December and our CXO Summit in May at the Nixon Library. We also are participating and hosting several webinars, this included, as well as regional events that connect our leaders in Southern California. And then, of course, we always enjoy opportunities to network. We have a large annual golf tournament that we do in the spring. So together, we're looking to build a community that drives real impact in healthcare. Next slide, please. High-level overview of those events that I shared. Again, I believe this slide deck will be available after the event. And then finally, next slide, I believe. Is that it? That one might be it. So on the prior slide, Eston, if we can go back just a minute, I highlighted 3 areas. We are still looking for some additional volunteers, and those 3 roles are actively open. So if somebody is interested in being a part of HIMSS Southern California, contact Midori or myself. I believe we also have our program chair on today. So there's a number of people that can be contacted, but happy to have a conversation and find a place for folks that want to be involved and volunteer. That's SoCal HIMSS. Thanks, everybody.
Thank you so much, Mary Beth. We appreciate it. And then without further ado, I will pass it on to our amazing Dr. Hayden Shafer. I'll give a little bio about Dr. Shafer. Dr. Shafer is a family medicine physician and assistant professor at Vanderbilt University Medical Center and core faculty within VUMC's LGBTQ plus health clinic. Additionally, Dr. Shafer is a curriculum director for VUMC's LGBTQ plus health fellowship. and a course director for the undergraduate medical school LGBTQ plus Health Integrated Science course. Dr. Shafer is one of the founding providers of the Transgender Care Program at University of North Carolina Family Medicine Center. Dr. Shafer provides expertise in the delivery of primary care to transgender and gender diverse individuals in the Southeast United States. Thank you so much, Dr. Shafer, for being here and sharing your expertise. I will go on ahead and pass it over to you to share all the knowledge that you have with us.
Thank you so much. I'm going to go ahead and share my screen here so we get this pulled up. And then launch. Okay, does that look appropriate for everybody else on the call? Can we see the presentation? Excellent. Okay, well, thank you so much for that lovely introduction and for inviting me to speak with you all today. It's really humbling to receive this invitation, and I love for this to be as conversational as it can. So certainly I'm looking forward to any questions at the end. So I'm going to be talking about how we have enhanced LGBTQ healthcare.
Sorry, Dr. Shafer.
Yes.
Just so you know, we're able to see your notes. So I think it's in presenter view, and I think there's a.
Hang on. What about now?
Slideshow. Yes, that's perfect. Thank you so much.
Okay, you can't see my notes anymore. Okay, we have to have some surprises baked in, so it's okay. All right, so I want to give a shout out to people who helped me prepare this presentation, version of this presentation in the past, which is my collaborators at Vanderbilt, Dylan Hughes, our pharmacist, with Vivid, Sarah Schott, licensed clinical social worker, and Shaylin Vanderblomen, who's one of our surgical PAs, have contributed to this presentation. And our learning objectives for today are going to be looking at the role of the EHR within LGBTQ-focused healthcare and how their needs within the EHR may differ from cisgender straight counterparts. We're going to look at how our multidisciplinary approach to this within Vivid has been effective at us achieving these goals. And then we're going to look at particular improvements that we've been able to make for them to function within a massive health system like Vanderbilt University Medical Center. So I want to pause here because we're going to start with some polls to get some information from you all.
Yes, and I will be the one starting the polls. Let me know if for whatever reason anyone can't see them. They should be coming up. And there are just 2 questions that should be posed to you all. Seeing some answers coming in. Go ahead and hit here. And share results with y'all. Let me know if y'all can see the results as well. So Midori and Hayden, I don't know if you wanted to talk more about this or.
Certainly. So we've been really partnering across the state of California to see sort of where organizations are on their efforts to collect SOGI data and really evaluating whether it's supporting affirming care. So thank you so much for answering the polls. this is very consistent. We actually, Shannon, who could not be here today, and I have partnered with State of California and the Cancer Plan to actually do a survey out to different NCI designated cancer centers and comprehensive cancer centers. And this is about what we're seeing in the industry, where there's about half of the folks are really jumping in and seeing how they can collect the information. And there's still folks trying to figure out what to do around some of the education and ways of collecting this so everybody feels comfortable. And so I'm looking forward to hearing Dr. Shafer's talk today as we get to hear about Vanderbilt's experience in this particular area to see if we can take some best practices and apply it to the learnings to our community. The second piece is really around, so you're asking the questions, but is your EHR really supporting and helping provide prompts for affirming care? And so this has been a little spotty, where there's a lot of opportunity to still work with folks in the EMR to see what they can do to help support providing affirming care and giving confidence to our patients that we are actually paying attention. So that's about 20% or so of folks are confident. Here we show 33% of the people on the respondents on this call, which is great. That's encouraging. But about 20% or a fifth of the people in California have been focused on this particular effort for affirming care. So that is consistent, and I will pass it back to Dr. Shafer.
Okay. So I want to start by kind of giving an introduction to Tennessee, what our populations are like of our patients and the role of VIVID. So here, for some reason, my slide is not advancing. Okay, here we go. So on the left, you'll see our VIVID banner, which is our logo and includes our number to make appointments with us. And really, we are focused on offering comprehensive medical, surgical, and behavioral health to LGBTQ patients throughout the entire state of Tennessee. We also collaborate significantly with our local community and local LGBTQ organizations. We also spend a good deal of our effort with education. We are one of 6 LGBTQ health fellowships within the US. And we also are fully integrated within our medical school. And then we also have a research component of our program. So this is a picture of the state of Tennessee. I have my laser pointer out here. So what I like to point out about this is even in this very long picture, I can't fit the entire state of Tennessee within it. We're a very long state. If you're to drive end to end, it's about 10 hours. And so we encompass quite a range of individuals. Our major metro areas are going to be Memphis, Nashville, which is the major areas of Vanderbilt's clinical enterprise, and then Knoxville and Chattanooga. This is just a map of downtown Nashville. My clinic is down here in Berry Hill, but the main hospital is here. But you can see everywhere you see a little gray dot is some sort of Vanderbilt clinic. So we have a big catchment area within Middle Tennessee, but also as one of the major academic institutions in the Southeast, we pull a lot from our surrounding states. I have a number of patients in Kentucky, Alabama, Mississippi, and Georgia who commute to Tennessee to engage with our program as well. So if you look at our gender diversity data that we have in the state of Tennessee, you'll notice that this block up here in particular is representative of all individuals identifying as transgender. And so our largest percentage age group of patients is 18 to 24. But of course, we serve people from all ages. We have the majority of our transgender patients by percentage are Latinx in Tennessee, then followed by African American, white, and then Asian populations. It is estimated that it's about 27,000 people. This is data from 2020, so it's a little bit old, would be identifying as transgender or gender diverse. If you look specifically at Tennessee, we estimate that it's 3.5% of our adult population. And we do see in our state that there are higher rates of, and this is not just with trans and gender diverse individuals, but with LGBT identifying individuals through the whole acronym, higher rates of unemployment, un or underinsured, food insecurity, and living below the poverty line. You'll also see on this graphic here on the right that our population particularly skews younger, which is consistent with our patient population of our program, with fewer older patients. So if you look at the breadth of transgender care within VIVID, we involve care coordination of our patients within the program, comprehensive behavioral health, including what we call collaborative care. We have a collaborative care program between primary care, psychiatry, and our social workers who do counseling. Primary care, this includes gender-affirming hormone therapy, gynecology, fertility services, electrolysis and laser hair removal. We do have a pharmacist who helps with prior authorizations, and I'll go through what their work queue looks like. We offer full spectrum surgical services for our patients. We have dedicated insurance specialists to help us ensure that our patients have access to these services. And Vanderbilt is an enormous enterprise. It employs 48,000 Tennesseans and across all those little sites. So we need our care coordinators to help our patients get through these big octopus-like hospital systems for sure. We also engage on the educational side with weekly meetings, case conferences for our patients where we all come together, me and the 18 other specialists, to talk about patient cases to make sure everybody's on the same page, operational updates, and we do a monthly journal club. So that's an intro to us. We're going to talk about electronic health records. So just as a starting place, I noticed that people in the poll indicated that they do not collect SOGI data at their current institution. And what I would like to point out is that as of 2018, all EHR systems in accordance with the Affordable Care Act have to be able to collect SOGI data. So the best answer you can give is that your EMR should be collecting SOGI data, and it can, but it may not. The requirement is not that it must, it's that it can do that. And for those of us, just to be clear, SOGI data, when we refer to it in the purposes of electronic health records, is sexual orientation and gender identity data. So I like to think about this from the perspective of a theoretical patient, Autumn, who's going to be coming to our clinic. So this is really where most of our patients start, is going to be with this initial call, scheduling, and then getting into the first medical visit. So starting with the initial intake, when we created VIVID as a program, we realized that most issues that are occurring within the system is that we have patients who could, if you call just the general number to get scheduled with a new doctor at Vanderbilt, and if you said on the phone, I am transgender and I want gender-affirming care, can you send me to a doctor who does that? The person who is doing your intake is not typically collecting SOGI data at that time of that phone call, and instead deferring that to be done at the time that the visit occurs. The problem is that by the time you get into a visit with a provider, there are numerous areas where that individual is likely to have been misgendered or the use of dead names. So really the best time to collect SOGI data and put it in is actually in the registration process before they even step foot within the clinic. That guarantees that by the time they step inside kind of our safe space for them, that this information has already been concretely put in. So we developed our own dedicated phone line, which I know this is supposed to be about electronic health records, but an old school phone line has really helped us out about streamlining, because we know anybody who calls this number is uniformly going to have a comprehensive SOGI data input by a specially trained, what we call PSS, or Patient Support Specialist. Also, the acronym, if you do 54287, that's LGBTQ. So I think that's clever. If you look here at this template, this is what happens when you open effectively our SOGI box when you're registering a patient. And so at the top, you have sexuality, then on into gender identity, which you get to have the patient's stated gender identity, also a field for sex assigned at birth, the fields for patient pronouns, and the designation of the patient's preferred name. We also have this identifier here of, do you want us to use your preferred name in front of friends and family? So if somebody were to say, no, I don't want you to use my preferred name, I want you to use my legal name when my family is in the room, everybody who opens that patient's chart is going to get a pop-up, right when they get into it. So if that patient is admitted and there's other people in the room, we're avoiding that conflict. Down below here is the organ inventory. This is not usually done by our patient admin staff. We found that in feedback with patients, it was uncomfortable giving detailed organ inventory information to somebody who is not a care provider. And so this is completed ultimately by the provider at their visit. So we'll go through that in a bit. But just wanted to point out some of the fields here. So for gender identity, we have the choices are female, male, transgender male, other, which then will open a comment field for us to put in things that are not reflected within these buttons. We also have a prefer not to answer and non-binary. Patient sex assigned at birth, we have male, female, unknown, not recorded on birth certificate, choose not to disclose, other, or intersex. And then in patient pronouns, we have she, her, hers, he, him, his, they, them, theirs, just the patient's name, prefers not to answer, unknown, or not listed. This is one that I still feel is incomplete. We do not have fields here for neopronouns in particular. And so our patients who use pronouns that are not perfectly accepted by this, we're currently either having to say, we'll put this as not listed, and then we can make a custom note, but this is about as flexible as we were able to make our electronic health record be to this point, but that is always an area for improvement. Okay. So let's see here. So now I have filled out this. I wonder if I can take my laser pointer off. Okay. So what I'm illustrating here is, this is a video, you can see my cursor going. I'm filling out the organ inventory here. So I have listed that the patient is a transgender male. I'm going to back up here. Is a transgender male. Their sex assigned at birth is female. They are using he, him, his, they, them, theirs, or the patient's name. So you can have multiple selections for people with multiple preferences. And they do not want us to use their preferred name in front of their family. Autumn is their name. Autumn currently has a vagina, but they were born, patient currently has a vagina, but none of these other fields have been indicated. This next line is organs present at birth or expected to develop. So then the patient notes here that they were born, well, they were not born with breasts, but they were born with the cervix, ovaries, uterus, vagina, and developed breast later on. And then steps the patient has taken to transition. We have presentation aligned with gender identity, preferred name aligned with gender identity, and medical and surgical interventions. What's not been highlighted here is that their legal name has been updated or their legal sex has been updated. It's important to note that because this patient does not have a uterus, ovaries, cervix, or breasts anymore, you will notice that the patient here, where my cursor is currently on the left side and where you see care gaps, sorry, let me put my laser pointer on. In care gaps here, you will still see that this patient is due for cervical cancer screening in their health maintenance. Now, this is not accurate to the patient who no longer has a cervix. So that's where I'm going to show you that here with their legal sex being designated as female, and then their sexual orientation they chose not to disclose. Oh, sorry, we have to watch through at the beginning again. So now this is what our registration will always see since we've completed the field. And you will see, oh goodness, it's getting too much for me to balance the laser pointer at the same time. So I'm just going to take it off. Okay. What I wanted to show you here is that you'll notice in the top left under the patient's profile, it'll say male, and then there is an I information next to it. That is an indicator that if you were to hover over that I, it is going to say male, and then it'll have a pop-up, it'll say transgender male. So this is a way that when all of our nursing or patient support staff are perceiving this patient more so as male in all patient lists, rather than it coming up as female, which is not the patient's preferred gender identity. So despite that other field, I could type in the patient's preferred name as Autumn, I still actually have to go to this other field to put it in. This is some complicated tech answer that I can't fully understand, but you have to put it in two places for it to ultimately reflect. But now, after we close it, we'll see here in the top left that Autumn is going to show up in parentheses as the patient's preferred name. And so now here on my patient board, we're going to see Autumn is listed on the name, and then we're going to see their gender is transgender male. And this is hopefully going to be displayed to all care providers. Another thing that we have done is we have designated a flag for our patients. So you'll notice in the top left, next to the pink bubble, there is a flag with a number, and it says a 1. This flag, when we had previously done this presentation, was listed as what was called the transgender patient flag. This would alert anyone who's accessing the patient's record to know that this individual identifies as transgender. Obviously, as an LGBTQ health program, we don't just take care of transgender patients, we take care of everybody who identifies as LGBTQ. And that is not a complete representation of our patients. So we've now updated the name of this to be the Vivid flag. And this really just serves as a way to help us track our patients or to let other people who are accessing records know that they are a part of the Vivid program. In that form that the patient had indicated, they said they did not want to use their preferred name in front of family members. This is just within this flag, you can put any additional information that can be shared with other providers. If you wanted to put, where they live or who they live with, it's a free form that you could add any other additional information. What I wanted to show you here is because our patient, we completed our organ inventory to indicate that the patient no longer has a cervix. If I go into their care gaps and I refresh it, or you can see here that their pap smear is still showing as needing to be done, but that would not be accurate for this patient who didn't have a cervix. Now that I've updated their organ inventory, it has automatically been removed from their care gap registry. So this is important, not just for the patient's health and wanting to be as accurate as possible about what their health needs are, because patients see these care gaps and they wonder what they do or do not need. But this is also important to us as a patient-centered medical home to make sure that our health maintenance goals that we have for ourselves as an organization are accurate. And so we went through a lot with our tech team to make sure that the organ inventory actually reflects within the care gaps that appear for routine health screenings. This is one of our general note templates that you would encounter with a patient who's coming into the Vivid program. So you'll see these pink fields are areas where you can have choices to input text. This patient, for example, is going to be here for a telehealth visit, so we have to verify they're in the state of Tennessee and that they're at home. You'll notice that it's important that their preferred name at the top here shows up within the note template. Since patients are able to review all their own health records, it's important to us to make sure that the correct preferred name and pronouns are showing up within our own note templates. You're able to designate in that drop-down field their gender identity. Obviously, if that needs further editing, you can take that out and custom put on whatever you need. You're able to input your organ inventory by clicking these buttons here within. This is the first patient intake note. Sexual history, we generally say sexual partners are those assigned male at birth, assigned female at birth, people of all anatomy are not sexually active. And then we have a field for risk factors, depending on if they are at risk for sexual violence or would benefit from HIV prevention. So that's clinically what I would do and walk through with a patient kind of at their first visit with me. So then let's say I see Autumn, they are interested in being on testosterone therapy. This is when I get to get my pharmacist to help me with prior authorizations and making sure that their pharmacy data is accurate with their preferred name and gender identity. So our pharmacists actually are in clinic with us all the time. They participate in patient visits with us in terms of doing education and working through injection teaching and troubleshooting and so forth. And then we have external pharmacists in the retail setting who also help with us with prior authorizations and things. So general education on gender-affirming hormone therapy, HIV PrEP and PEP. They can schedule dedicated video calls to troubleshoot these processes. And then they do still chronic disease management that you would expect in a primary care setting, reconciliation, facilitating labs. This is a big one for us from an EHR perspective because we're taking care of people all over this giant state. We do a ton of telehealth. If they're outside of Middle Tennessee, they probably cannot get access to a Vanderbilt lab. So we're sending these to a Quest Diagnostics or a LabCorp, and our pharmacist or our nurse coordinator are the ones that typically help with contacting, setting up patient accounts, getting the labs over them, getting them back. Prior authorizations is a big part of this. We see a lot of issues when somebody updates their legal name with us, but not their insurance or vice versa, or with us and not their pharmacy or vice versa, that there's all these issues that get folded into the mix. And so having a dedicated person to help straighten that out and get all the systems to agree with one another is important. They help a lot with care coordination and scheduling when people are having medication issues. And I would say probably where they spend most of their time in the EHR is handling patient messages, right? When people are messaging the provider and saying, hey, I'm getting bleeding after I do this shot, or I'm getting this side effect, what's going on? It's nice to have a pharmacist right there to be able to field that question. And then of course, handling medication refills, which all of our refills are electronic these days. So these are some sample communications from our pharmacist. So starting in the top right box, you'll see what a typical message to me says when somebody is sending a refill request. This is what the pharmacist will have prepared for me. It will have been, they are requesting a refill for testosterone cypionate, the date of the refill, when is their future appointment, could it be renewed during protocol? No, it couldn't because something was missing. They will put in what their last labs were for me to review before I refill the medication. And then they'll put a separate note here of what is their follow-up plan. You can see here on the bottom right a common message that's going to one of our providers to the pharmacist would say, hey, I just saw a patient who's 1 year on hormone therapy, experiencing financial stress, end of a relationship, partner moving out, trying to find a roommate, share housing, but is going to not be able to get their medicine because of these challenges. Can we get them enrolled in the MAP grant, which is our medication assistance program for patients who are experiencing financial insecurity that can't pay for their medicines? So they would be able to go through this process. you can basically you can see the theme of all these messages. Dylan, our pharmacist, can you help us? So we rely on these messaging systems quite a lot to communicate with one another. This is just example of, say a message I sent to Dylan. Hi, this level is way too high based on his injection 4 days period. Can we check with him on how he's doing this, right? Being able to set up a virtual visit to be able to ensure accuracy of injecting medications. We have dot phrases that include commonly used GoodRx prescriptions that we can use with patients to help improve cost effectiveness. And then we keep an up-to-date Excel sheet. This isn't specifically within the electronic medical record. It's outside of that, but it's within our system. But we keep a running list of prices of all of the medicine in our areas at each of the particular pharmacies that we send to patients to choose the right place for them. Lastly, that we have a wide array of dot phrases that we prepare for patients, commonly asked questions about if their PA was approved, if their PA was denied, where to buy injection supplies, if their insurance won't pay for it, how to do like our subcutaneous injection guide or intramuscular injection guide. So things that have worked well, and then including in these like purchasing guides, like for needles and syringes, having hyperlinks built in within them makes it very easy for just people to click on it and it goes to an area where they can buy it and get it shipped directly to them. Our social workers, they participate certainly in evaluations of our patients from a behavioral health standpoint, as well as care coordination for services out in the community. They do a major portion of our letter writing for our patients seeking gender-affirming surgical care and can coordinate with psychiatry. So they have their own dedicated, you can see highlighted in red on the left, dedicated message basket, right? So if I have a need of one of our social workers, because we don't have just one, I'm able to send it to this queue that we've been able to develop. So developing dedicated queues within Vivid for each of the teams has been integral to keeping things organized. These are some examples of messages that have come through of behavioral health referrals that they're hoping to get care coordination with. This is just referencing that in the letter writing, in particular for gender-affirming surgeries, it is very important that the preferred name is listed. The legal name also must be listed in somebody's letter when it's going to their insurance. And so understanding and explaining to patients that both those things need to be there, but making sure that the information is as accurate that we have completed at our first visit. This is a sample work queue for consults that come into our licensed clinical social workers. If I put in a referral to collaborative care so somebody can start engaging in therapy, this is a typical work queue that will go to them. And then just like with pharmacy, we have a use of frequently asked questions that we can just reply to with dot phrases. So for example, on the left here, you can see these are outside of Vanderbilt behavioral health referrals. So we keep basically a running list of our local community resources for behavioral health that we've vetted as safe spaces for our patients, that we will send this out all the time, again, with hyperlinks. We can share them with all of our providers. And then certain, commonly asked questions of like, what do I need within a letter? Or say I have a community therapist who's trying to write a letter for my patient, but they've never done one. I get a dot phrase of kind of everything that they need within that letter. Just like with pharmacy, they use a lot of message basket and pools so we can be communicating to one another between our visits. We have shared patient lists between the behavioral health providers in case they're covering for one another. And the last section we'll talk about is our surgical pathways. Now, of course, not all of our patients engage in surgical care as part of the Vivid program, but for those that do, we want to make sure that this is as seamless as possible because there are so many moving parts to it. So we created a surgical pathway, which is a process at Vanderbilt where basically as a physician, you can raise your hand and say, I notice we do not have a process within the EMR to get someone from start to finish of this thing that I do all the time. And one of those things was from start to finish, how do you get somebody in for gender affirming surgical care? They're able to work with all the physicians and people engaged in this care to establish what our best practices are going to be. And then we can use this for quality improvement and ideally all for improved patient outcomes. So what we were able to do is develop a pathway. Once it's developed, a subcommittee reviews it. They go through processes and review pathways to try and add pieces here and there, remove pieces of red tape, and ultimately make a recommendation for this to be published within our EMR. So this is what one of our pathways looks like. It starts here in what we call a smart set. So when somebody is starting gender affirming surgery processes, you would start by clicking a pre-consult in the middle there, if it's an in-clinic consult after that, or their post-op visit. Once you say click on this pre-consult, it will pull up this field. It allows you to designate what type of surgery that the individual is listed in, and then that will go into what the pathway is. So this then establishes what's called a surgical plan for a patient. This is a running list that anyone can access to see where somebody is in until the patient has surgery, has their post-op visit, and the surgery is closed. You're able to designate, say, for example, this patient, what their previous surgeries have been and what they're interested in doing. So, for example, this patient has already had a mastectomy, and they're looking to have a revision of that in this example. So you're able to create a custom task list for someone who's going through this surgical pathway. So you need to ensure that the patient has their behavioral health note and consult, that we've had their insurance approval, their social transition, which is recommended by WPATH guidelines, their vivid pre-op telemed appointment, and their VPEC appointment. This is as you complete these tasks, you can hit complete, complete, or not needed, depending on the patient. And this all goes into the flow sheet to basically say, when is the patient ready to schedule their appointment after we've completed all of these things. I want to point out, this is very unique surgical needs of transgender and gender diverse patients, right? Somebody who's going through this process, say for a knee replacement, may not have these particular details of have they socially transitioned, have they had a behavioral health note. So these were custom needs we had to ask our EMR to create so that we could actually track them through these unique surgical needs. You'll see that as things are cleared, we get these nice filled in bubbles of when people are ready to go with certain things. And then have the opportunity to take someone out of the program after the surgery is complete, and then their insurance documentation as well. This goes into a big flow sheet. You can end up actually searching patients by where they are within this pathway. Say, for example, you wanted to look at all of our patients who are currently ready to submit to their insurance but have not. This is good for our insurance planners of like, okay, who's next on the work queue? You can sort by where their specific need is. And this is the more horizontal frame here is more what it looks like to our insurance planners of where they are in each of these processes. So as many successes as we've had rolling this out to tailor to our patients' unique needs, this is not perfect, right? So continued challenges are that not all pronouns are represented within this, though it seems like it would be easy to integrate. This is something that is decided more based on our particular electronic health record producer, which for us is Epic. If it doesn't have that capability baked in, it's just advocating for them to add it. Preferred name is not standardized across all note templates and users. So for example, I may be very diligent about making sure the preferred name is everywhere, but you could just as easily, in say orthopedics, have a note template that if you were not using the specific way to autofill a preferred name, then someone's legal name is always going to show up. And so While within the VIVID program, we're very good at being consistent with this. Of course, at a health enterprise, we want to try and make this as consistent across all specialties as we can. We have dedicated people within our VIVID program who do outreach and education to all of our non-VIVID specialists, including education on how to get their note templates to reflect this up-to-date information. The sexual orientation tab leaves something to be desired. I excluded this because it's so terribly embarrassing. There's a dedicated sexual orientation tab, and it basically says you can be straight or not straight, which is comprehensive, but it would be nice if there was other options for us to be able to track our patients' information. That said, this is something we have a patient advisory committee who we always gain their feedback anytime we introduce or thinking about introducing new changes. And there is always a push and pull of how much people do or do not want documented within that medical record as well. And what questions kind of borderline on invasive to an individual. So right now, straight and not straight seems to be comprehensive, but lacks detail. And then communications between hospital systems and poor. I think we all know this. All this nice data that we get to do here, if they go over to my friends at St. Thomas, one of our other major hospital systems here in Nashville, no consistency in preferred name, gender identity is going to come across within a Care Everywhere record request, right? So this is a continuous need for improvement across all systems. And that is my last slide, so I'd love to open it up to the questions.
Great. Thank you so much, Dr. Shafer. Amazing. You can see I have Epic as well in my organization, as well as a lot of people do in the country. And it's always a challenge to get the right configuration. So I applaud you all for how much you've really put into this. So this has been really amazing to see. So thank you so much for presenting. My first question to you is, you've emphasized the importance of SOGI data in the EHR. What have you seen as the benefits for the patient and the clinician when this information is available at the point of care? How are they using this information?
Certainly our patients are benefiting in that they are being addressed properly more often throughout a large health system, and that they are more likely to have an inclusive, supportive, and affirming visit where even outside of our own program. Certainly we guarantee that within our program to the best of our ability. But really the goal is to see these kind of fall out after effects and trickle out within the rest of the system. And so when we're able to input and take this all in, it doesn't just help out our program, it helps out the patients in every corner of the health system. So I'd say that's the main benefit to our patients. I would say to our providers, really it's just a knowledge deficit. Most of our providers would be very interested in including this information if they knew how to do it. And especially for health systems that use Epic, it's so huge, and nobody likes to spend their free time exploring their EHR. It's nice to make it as simple and clickable as possible. And so I think that's been the nice part, is empowering physicians to add information even in other specialties outside of our own.
Great. To that end, technology is only half the challenge. How did you approach provider training and workflow design in really the collection of the data to make it meaningful and sort of present, so that they're not clicking all over the place?
So we were able to, as we introduced these new mechanisms of how to record this information, one is to make what we call tip sheets available to all providers once we have a workflow established. In our system, I'm what you would call a clinician champion with our EHR. And so my kind of volunteer job that I have with that is to take new information and distribute it to everybody that I come into contact with. And so it's developing listservs and relationships to say, hey, we've got this new thing. This is how it goes. This is how you get to it. And then, just me individually, anytime I see that it's done wrong, you get a happy little message from me that says, hey, just wanted to let you know this is, now a possibility and we can do it this way and so forth. Recognizing that, again, much of this information isn't actually done by providers. It's usually done by our patient support staff. And so we wanted to make sure that all patient support staff are aware of these processes. And so we were able to work with their management to include this as a part of every new person's training when they're onboarded. And for existing patient support staff to go through that same process of a tip sheet of making them aware. We found that has been good, not great, as like with most onboarding and training things. I don't know whenever you start a job, like how much you necessarily pay attention to the slideshow that you click through to get through. We can't stop people from doing that. So that's where we find higher yield of like, we're going to have we've definitely found that it makes a much bigger impact if Dr. Shafer doesn't come to our patient support staff and tells you how to do it. We need a champion who is already a patient support staff, who is passionate about this work, to be the person to show their coworkers how to do it. And so that's where we actually really succeeded, is actually finding people within who are already passionate about this to help them distribute the information when we see this going out.
That's awesome. I love the physician champion sort of approach, but just sort of overall that super user or champions that are at each job role because they know that day in the life. So that's amazing. So since we've talked about some of the barriers, whether it be technically, culturally, or regulatory, that organizations are really facing and making, the EHRs truly inclusive. What are some of the additional barriers you've seen around making it more inclusive?
I think certainly we've had unique challenges this year with, we have our own state laws that have been passed around DEI requirements. And some of this could be construed as DEI measures. And so the lens over continuing this work now is more highly scrutinized than it's ever been to make sure that we're in compliance with our local state laws. My fun fact that I remind people is that ever since we were able to popularize the chosen name or preferred name field, is that over 35% of our patients at Vanderbilt indicated in our surveys that they wanted this field. Well, we don't have 35% of Vanderbilt's patients within our program, right? So all patients benefit from being able to say, this is the name I go by, if it's different than their legal name, and to have that show up on their wristband so that people are calling them by the name they actually go by. So this isn't just a LGBTQ issue. This benefits everybody. And so being able to try and, reinterpret or market inclusive practices as ways that benefit everyone's safety and autonomy. But it does mean I have to, when I go to my stakeholders, I may have to position my my asks a little more differently than I used to.
Yeah, absolutely. I know that's something we're all facing, particularly for grants and funding. It's been a challenge. How do you see EHRs really becoming more inclusive in practices over the next 5 to 10 years? Where should organizations really be investing their efforts?
I think it would, as patients have gotten used to engaging with EHRs, it would be nice if patients are able to control this process more on their own. So like in self-registration, as long as we provide fields for patients to input their own information, allowing what they designate that they want to see reflected within their own health record, that if they can put that in without having to go through a patient support specialist, whether that's put in through the app or with a form that they fill out, that to me is the best new thing to focus on now that patients have become more comfortable interfacing with these patient portals. So that's what I get excited about. I would say the other EHR thing we're all contending with now is AI auto-scribing. So for people that are maybe not aware of this, ambient listening is a very widely popularized, kind of exploded this past year with the introduction of AI into the healthcare space, where basically you have a microphone listening to you during the visit, and then this auto-populates it into a patient note. I certainly have found that you cannot rely on it in any capacity to get pronouns correct. How it decides to make the judgment of who or what is speaking to you is all over the place. And so continuing to work on the accuracy of that within each of the individual AI listening. Ours, you're able to, if you notice it's incorrect, you can open the file back up and ask it to change the pronoun designation. Or what I do for it is I make it document everything as gender neutral as it possibly can. And then I manually can choose to update it. And so it's just for advocating for, as we get new tools, it's continuing to advocate and say like, hey, here is where your tool is or isn't working well in an LGBTQ health space.
Very good. Great advice. Ambient listening is really taking off, and we are also seeing some challenges with capturing the information. I did love seeing the templates that you've worked with your providers on, specifically having some documentation templates. What do you think the one single innovative thing that you could do to help support and really change the way gender affirming care is delivered? What tools or what EHR configuration, or like what is that sort of the one thing that you think really made a big change?
I think, of all the things we've done, I think that surgical pathway creation we've did has really helped streamline and organize the way that people go through the surgical process, because there are just so many unique moving parts that are really not a part of any other surgery. And when you have a health system that does a whole bunch of surgeries, and you have unique needs for one particular type of surgery or multiple within there, being able to capture those unique needs within the EHR helps keep everything organized and allows you to get people through this process faster, right? And as we get people through the process faster, that allows us to expand how many times we offer these surgical interventions, which allows better access for our patients in the area. We're one of the only surgical centers for gender affirming care in the entire Southeast. And so we get people coming from over 8 states generally to have surgery with us. And so increasing our capacity is a huge part of that. And we can really thank the EHR for getting us through that faster of keeping track of things. Yeah.
That's amazing. You can tell that was sort of custom developed, right? You had mentioned that. So that's really amazing. With smaller organizations or folks that might not have sort of the technical know-how or the resources to be able to make these changes, what are some of the first steps smaller organizations can take to promote equity in their EHRs?
Honestly, most of our ideas in terms of where to focus and improve end up coming from our patient advisory councils or committees of listening to feedback from the patients of saying like, hey, I keep seeing this issue with my note. I encounter this problem when I go to this area within the system. What can we do about it? And then really going back and doing a root cause analysis of where is the most common problem starting, and then trying to just kind of get through it from there. And it's great if you can, have the ability with your tech teams at your respective places to bend the EHR to do that. If it can't do that, that's when you end up supplementing with other tech alongside the EHR. I use, for example, like our Excel spreadsheet of all of the medications that we keep up to date for our patients. Like, that's not something our EHR can do. If it could, that would be great, but that's asking quite a bit. And so using other tech that's safe and secure to try and get around that.
Great. Great advice. A lot of folks don't have these patient family advisory councils, and sometimes, those little tidbits or those kernels of, possibility comes from those groups. So I think that's wonderful, wonderful advice. One of my last questions here is, how can leaders and policymakers and communities making more the EHRs more inclusive and a standard? What are your thoughts, particularly with this political climate being very sensitive?
Yeah.
What are your thoughts on that?
That's again how I end up framing it. When I go down to the folks I know you're not familiar with Wilson County, but in Wilson County, 2 hours south of me, I'm from Tennessee. I'm born and raised here, so I can say whatever I want. When I go down to my good old neighbors down in Wilson County, and they're like, we're not going to talk about no pronouns or nothing like that, I immediately reframe it and say, really, where we all agree we want to be is these are patient safety issues, right? If patients are feeling uncomfortable being here because their needs are not being paid attention to, that is unsafe for the people that live in your county, right? Them not accessing care is not safe. And you may view them as, if they're not in my door, it doesn't pertain to me. But generally, people, when they go into healthcare, they want to help people. And so that's my appeal to them, is to say, I am not necessarily asking to change your fundamental beliefs about the world. I am asking you to say, these are people that want to feel safe at the place that we all work in, and that getting this information does make them more safe. And I've got all my fun data to show them about, who's going and what, and who's putting off care because they're afraid of how people are going to talk to them, so on and so forth. And so I like to view it in this time of, tumultuous opinions about this, particularly in a very red state, is patient safety and patient privacy. Everyone here agrees that we should not have outside forces meddling in, the doctor-patient relationship of what's going on. Because, they wouldn't want me, they wouldn't want the governor coming in and telling them what they could or couldn't do at their doctor's visit, right? And so just ensuring that the autonomy and the safety is preserved. Those are my wins.
Great advice, and thank you for your advocacy. So much great work, particularly with you being a referral center in such a areas where that can be quite conservative. Those are great messages. Is there any sort of ending sort of words of advice or sort of thoughts that you have on the subject? And thank you again for presenting this amazing work that you've done.
I think my kind of cutting edge thought / fear is, one of the things we grapple with a lot is, while collection of this data, me as a scientist and a physician, I love getting this information. I love to look at the numbers. I feel better and more equipped when I can represent the people that I have when I have that info. But I constantly hear this concern that this information that's being collected is not actually going to be private. And we've had this issue already at Vanderbilt. Our state attorney general requested records of transgender patients who were insured through TennCare and state health plans, right? And there were legislative efforts this year on 2 House and Senate bills, respectively, that were going to require that any patient insured by state health plans, Medicaid, Medicare, automatically, I have to report their hormone therapy, their doses, their duration of treatment, and all surgical interventions to our health department database. And same thing for any patient, regardless of insurance, who would detransition, they're going to start a new detransitioners database. These are the kind of the legislative actions going on in Tennessee. And so when I see all this happening, now I'm getting, feedback from my patient advisory council of like, don't list in there that I'm trans. Don't put in there that I have pronouns. Do not put on my problem list I have gender dysphoria. I don't want any of that in there. I want it scrubbed out. And I hear that need and hurt and fear. And it is kind of, I am still grappling with like what to do with that information, because a lot of times it's like, okay, well, if it's already been that way in your health record and we go and remove it, that action of removal is also recorded, right? So while that may feel like that is the just thing to do to protect someone's health, privacy, and safety, in actuality, it may make them more vulnerable. And figuring out how we grapple with this, we know that from a research perspective and health safety perspective, that this collection of SOGI data is so valuable. But for people who feel very unsafe right now, is this the best time to be taking in more information? So I don't know. I'm not sure I've got the answer, but I would love the conversation.
That is a great conversation, and one that I know that many are having. How much do we push for that protection of privacy versus needing that information in order to do the right things for the patient? And I think that that is a huge conundrum, and definitely one that we could probably have a whole program on this. In fact, we should have a good a program on this, because I think a lot of people are struggling with this, and hearing from even folks in the community and our these initiatives that are happening to actually support being more transparent and having the data elements available for us to not have biased data sets and provide the right thing for patient care. It's really difficult. So thank you so much for your time today, and provoking great thought questions for future topics. I'll turn this back over to our folks. Am I turning this over to you, Lou, or to Aston?
I'll take it.
Back to Aston. All right, Aston, thank you.
Yeah, thank you all so much. I know a couple people had to hop, but Dr. Shafer, thank you so much for so much valuable, great information. I know I personally learned a lot. Midori, thank you so much for holding space for questions. I do want to see if there's any questions in the folks that are left, just while we have Dr. Shafer here. It looks like Jay may have a question. Is there any way that medical organizations can work together to advocate for EPIC to make certain changes regarding the neopronouns issue?
That is, certainly, I'm not sure that the EHR owners are necessarily going to respond to like medical organizations asking them, like the AMA, like so on and so forth, but they will ultimately respond to customers. So it's us, who pay for their product. And so, as my role as a clinician champion and builder within our system, we do interface with our local EPIC reps to be able to continually give this feedback. And believe it or not, they've been building out a expansion to include and support neopronouns within EPIC based on our feedback. It is going to come at a cost from the institution to expand and like purchase that expansion. And so then it kind of turns back to the advocacy within your own organization. But yeah, I would say the best way is maybe not from our professional organizations, but more from a customer attitude.
Thank you, Jay, for your question. Holding space just to see if there's anyone else that has any more questions. All right, we got a huge thank you from Lou. And yes, thank you both again. I'll go on ahead and close us out. At this point, hopefully you all can see my screen here. This is just to share the work that, moving backwards. this is just to share that we are still doing work on this project on LBTQ SOGI data collection in cancer care. We are actually currently hoping to conduct 2 to 3 site-specific trainings at cancer clinics, providing educational materials and technical assistance and other information. So we're looking for some folks that may be interested. So if you or someone you know, or a clinic that you know may be interested in trainings, specifically site-specific trainings, please reach out to me. My email is awilliams@healthaccess.org. You can also send an email back once we send out the slides and the recording if you are interested in having some specific trainings talking more about SOGI data. So thank you all for being here. I also want to make sure that you're able to fill out our survey. This is so helpful for us, not only to continue this work, but to see what information you all would like. We have created educational materials and all of those things, and I can also link them in the email that's going out so you can continue doing this work. Again, I thank you all so much for being part of our community and coming today. I thank everyone who was a part of this wonderful webinar. And I hope that even with everything going on, that we're still able to continue this work safely. So yeah, just checking in to see if anyone else has anything to say before we close out.
Just wanted to actually thank you, Asen, and the team, Lou, everybody who's put in a lot of time, Ari, into the work. We need people like you to keep us pushing forward and holding healthcare accountable. So thank you all for everything that you've done.
Thanks, Midori. All right, thank you all. We'll go on ahead and end. Have a great rest of your week, everyone. Take care.
Yeah.
Bye.